This evening, Young Nigerian Neurosurgeon Forum webinar. It's a monthly webinars, and the program has actually enriched many of the young Nigerian neurosurgeons and also world neurosurgeons, both people in training and the young neurosurgeons. So this evening we'll be having another section. Actually, today is going to be an operative section. The anchor or the coordinating center for this month webinar is Ahmadu Bello University Teaching Hospital. And our erudite professor, Professor Ozo, will be senior faculty for the day. And our moderator is Dr. Fred Ejimudo. On this note, I want to hand over to the moderator to moderate this evening program. Thank you very much. Dr. Ejimudo, over to you, sir.
Good evening, professors and colleagues. The topic for today is retrosigmoid approach, which will include anatomy of the cerebellopontine angle and the indication with the operative principles. As I've said earlier on, the presenting center is Ahmadu Bello University Teaching Hospital, Zaria. And we have two presenters for Dr. Usamat Muhyiddin and Dr. Saidu Abdulkareem. Welcome to this session. Each presenter will have 25 minutes each to present. Over to the presenters now, please.
Good evening, professors, senior colleagues, and colleagues. I am Usamat Muhyiddin, Senior Registrar, Neurosurgery Division, Department of Surgery. Myself and my co-presenter, Dr. Abdulkareem Saidu, will be presenting retrosigmoid approach to cerebellopontine angle. I will be following this outline: introduction, historical perspective, relevant anatomy, and indications. Diverse range of pathologies occur in cerebellopontine angle, ranging from tumors, cysts, and vascular lesion. Vestibular schwannoma is the commonest lesion that is seen in this angle. Although the lesion is mostly benign, it has potential to cause significant morbidity and mortality. And this is due to the important neurovascular structures that are located in this region, and also the presence of brainstem in this region. So even if a tumor or if a lesion is benign, so compression on these structures can have significant morbidity on the patient. And if it compresses on the brainstem, that can cause significant morbidity or even mortality. Several approaches have been utilized in order to remove lesion in this angle. Over time, these approaches have been refined until this period when we have modern approach to this tumor with a very good success rate. So some of the approaches that are being used to resect tumor in this region include middle cranial fossa, pre-sigmoid approach, or retrosigmoid approach. So middle cranial fossa and pre-sigmoid approach, one has to drill petrous bone that is in the way or in the trajectory of the CP angle before one can achieve this. While for the retrosigmoid approach, one doesn't have to drill bone until one gain access into the CP angle. Choice of approach depends on the anatomy of the tumor the neurologic status of the patient, the hearing status, the facial nerve status, and then the experience of the surgeon. Retrosigmoid approach happens to be the most versatile choice when it comes to approach to pathologies in the CP angle. And this is due to the fact that it gives a panoramic view of the CP angle, and then it exposes the neurovascular structure right from where they are originating in the brainstem till their exit points to other compartments of the brain. Growing evidence supports the fact that the goals of CP angle surgery is best achieved with retrosigmoid approach. And the goal of the surgery is that a complete resection of the tumor with no neurologic deficits. Adequate familiarity with complex anatomy of the CP angle is a prerequisite to achieve a good outcome. Total resection is achievable with long-term outcome with this surgery. However, if the tumor is large and it's adherent to the neurovascular structure, complete resection may not be achieved. Now, going by the way of history, several surgeons have made impact in the CP angle surgery. And this has improved over time. It has undergone several modifications and refinements until today, when we have a microsurgical approach to resecting tumor resecting lesion in the CP angle tumor. In 1890, von Bergmann was the one to perform cerebellopontine angle surgery, though the patient died intraoperatively. And in 1894, Sir Charles Balance was the one to perform a successful removal of CP angle tumor. And this was achieved through right posterior fossa craniectomy. In 1895, Thomas Annandale of Edinburgh removed vestibular schwannoma via a unilateral suboccipital craniotomy. In 1898, F. Cross was forced to use retrosigmoid approach, and then he employed Faraday stimulation to differentiate the facial nerve from cochlear nerve. And what this entails is that he uses electrical stimulation of these nerves so that one can differentiate the facial nerve from vestibulocochlear nerve, especially in the patient that has hearing deficit. Before surgery, one has to differentiate the vestibulocochlear nerve from facial nerve so that there won't be injury to the facial nerve. Then in 1903, translabyrinthine approach was described. In 1905, Sir Victor Osley achieved total resection of CP angle tumor, but the surgery was complicated by brainstem ischemia. In 1970, Harvey Cushing was the first to perform intracapsular tumor removal in vestibular schwannoma surgery, and this improved significantly the morbidity and mortality following CP angle surgery. And in 1961, following the advent of microscope, he employed microscope in order to excise vestibular schwannoma, and this further improved the outcome in CP angle surgery. In 1966, Peter Janeta performed microvascular compression through a retrosigmoid approach. In 1967, Olive Kroner contributed by further developing the modern technique of retrosigmoid craniotomy. Then anatomy of CP angle. CP angle is one of the systems, one of the CSF systems in the cranial, in the brain. And it's a triangular space that is defined by superior and inferior limbs of the cerebellopontine fissure. As we can see in this image, so this is the image of the brainstem and the adjoining cerebellum. So the cerebellopontine fissure is a is a cliff that is in between the pons and the cerebellum. And the superior limb of it is what my cursor is on. And then the inferior limb of it on the right side is what my cursor is on. So the apex of this limb is located laterally, and this opens medially with the contents of the CP angle. And then this CP angle is bonded medially by the pons itself, as you can see here, and then it's bonded laterally by the cerebellum, and then anteriorly by the petrous apex, as you can see on this image. And then the contents of the CP angle, there are several contents present in the CP angle. So it ranges from the cranial nerve 5 to cranial nerve 11 are present in this, though some of the ones that are concerned majorly with the CP angle surgery is the one that those ones that are located in the middle. I will talk as we move ahead. I will talk about the layers of neurovascular structure present in the CP angle. So the contents include trigeminal nerve, abducens nerve, facial nerve, vestibulocochlear nerve, and the vessels. So we have superior cerebellar artery, anterior inferior cerebellar artery, and we have variable number of draining veins. Example is superior petrosal vein, then the flocculus of the cerebellum. So in this image, you can see the flocculus of the cerebellum there, my cursor is on, and then the correct plexus protruding through the foramen of Luska. So just anterior to that, you can see a transparent substance just anterior to the flocculus here. So that's the correct plexus of the fourth ventricle that is protruding through the foramen of Luska. Now, this is a magnified image to better explain the structures that are present in the CP angle. Now, between the junction of the pons and the medulla, called pontomedullary sulcus. So that's where the cranial nerve 6 to 8 exit the brainstem. So the most medial of them, which is this, the cranial nerve 6, as it exits through the sulcus, it ascends up anterior to the pons. And then this one is the cranial nerve 7, as it exits lateral to the cranial nerve 6, and then lateral to the cranial nerve 7 is cranial nerve 8, vestibulocochlear nerve, as they are on their way to internal acoustic meatus. Then this image illustrates, give a view of the CP angle, and it shows the neurovascular, especially the nerves as they are originating from this brainstem, their point of origin, and then their point of exit, the foramen through which they pass through. As you can see, this is for cranial nerve 7 and cranial nerve 8, as it exits through the internal auditory canal. And this is cranial nerve 9, cranial nerve 10, and 11, as all of them exit through the jugular foramen. And this cranial nerve 5, as it exits through the Meckel's cave into the middle cranial fossa. So one notable point here is that the points of the entry zone of these structures in the brainstem are the entry zones are always constant. The anatomy is constant. So meaning that no matter what, if the surgeon will always once one locates the brainstem, these structures are always there. And then also at the exit point, at the Meckel's cave, at the internal acoustic meatus, the anatomy of this structure, they are always constant. So once one is able to locate this foramina, then one will always find these structures there. So where the issue is in between these points. So if there is a lesion that distorts the normal location of the fetch, then one will begin to look for these structures. Then the neurovascular complexes in the CP angle are divided into upper neurovascular complex, middle neurovascular complex, and lower neurovascular complex. And these are done in relation to the branches of the vessels that are taking their branch from vertebrobasilar system. So superior cerebellar artery alongside with cranial nerve 3, 4, 5, middle neurovascular complex, the anterior inferior cerebellar artery in relation to the cranial nerve 6, 7, and 8, and lower neurovascular complex with posterior inferior cerebellar artery, that's spica, in relation to the cranial nerve 9, 10, and 11. And this is the image depicting what I just said is the upper complex. These are the vessels, the nerves, and then the related structures. So you can see here, and then there is the middle neurovascular complex and the related structures, lower complex. Then there is Roton's rule of 3, which is also relating to the neurovascular complex that we have in the CP angle. And this rule of 3, so meaning that we have 3 different parts of the particular structures that correspond in this space. For example, in the upper neurovascular structure, we have superior cerebellar artery, and the nerves that we have a cranial nerve 4, cranial nerve 5, and then that correspond to the midbrain. And then the middle neurovascular structure, we have ICA, pons at the, that same level, and then pica, cranial nerve 9 to 11, and medulla at that same level. So the significance of this is that once one is able to locate any of this structure, then one is always sure that the other structures in the same category are nearby, so that one will be careful not to injure them when one is exploring. And then another point, another significance of this Roton's rule of 3 is that in retrosigmoid approach, one has to retract cerebellum, which is one of the drawback of the retrosigmoid approach. So this also guide in where do you put your retractor, so that one can be able to assess the target structure. Now, anatomy of the internal acoustic meatus. So internal acoustic meatus is a foramina that is the exit point of cranial nerve 9, cranial nerve 7 and 8. The anatomy in this meatus is constant, as I previously alluded to. So this is divided into 4 quadrants. So the anterior superior quadrant, posterior superior quadrant, anterior inferior quadrant, posterior inferior quadrant, and then each in the anterior superior quadrant we have the facial nerve passing through it, and then posteriorly, that's posterior superiorly, you have the superior vestibular nerve passing through that, and then separating these 2 structures is the Bill's bar. It is here. It's a vertical crest that separates facial nerve from superior vestibular nerve, and then dividing the internal acoustic meatus into 2 is transverse crest. And then the lower half of this contains anteriorly the cochlear nerve, and then posteriorly the inferior vestibular nerve. Then this is the gross structure of the internal acoustic meatus, part of the posterior lip of the internal acoustic meatus has been removed here, so one can easily see the structures within the internal acoustic meatus. So the antero superior part, we have the facial nerve, and then the vestibulocochlear nerve divides into 3, then the superior, inferior, and then the cochlear nerve pass through their corresponding area. Then now coming to the surgical anatomy, in retrosigmoid approach, several structures are encountered, and then care has to be taken not to injure those organs. So a clear anatomy, clear knowledge of anatomy of these structures are very, very important. So starting from when surgeon makes skin incision, so care has to be taken not to injure the lesser occipital nerve when one makes incision. So one has to be wary of the location of this lesser occipital nerve so as not to injure it, depending on which type of incision is being employed in this category. Also, some muscles are also exposed during this approach, though the approach does not violate the suboccipital triangle that we can see in this image. However, it exposes the superior part of the obliquus capitis superior, and then superficial to this is occipital artery as it exits the occipital groove. Now, further, the occipital artery, it exits through the occipital groove and then ascends superiorly. So it passes superficial to the superior oblique muscle here, so that so in the inferior border of the incision, one has to be careful not to be too overzealous in dissection so as not to injure the occipital artery in this area. Then it's not likely that one will injure vertebral artery when it goes through, except if clear knowledge of anatomy is not the surgeon doesn't have clear knowledge of the anatomy. Then now, talking about the mastoid hemisphere vein, this is also an important structure in the retrosigmoid area. So there is mastoid hemisphere vein foramen through which this hemisphere vein passes through. So once raises the flap, one sees this foramen. Some authorities say that it overlies the junction between the transverse sinus and sigmoid sinus. So bleeding from this vein can be very dangerous, in the sense that depending on the size of the vein, so it can be very dangerous. So one has to be very careful of it. So when one exposes it, so one uses bone wax or electrocautery in order to stop bleeding from here. And then it's also a source. It may be a source of air embolism, because the vein drains into the sigmoid sinus. Also, this is to explain the guide to the first borehole that is inserted in the retrosigmoid approach. Several reference points have been used in order to cite the first borehole in the retrosigmoid approach. One of the structure used is asterion. Asterion is a meeting point of 3 sutures: the lambdoid suture, as you can see here, and then the occipitomastoid suture that is between, that is coming upward, and then the occipitomastoid suture. So the meeting point of these 3 sutures is what we refer to as asterion. So if one locates this asterion, in most people, this approximates the junction of transverse sinus and sigmoid sinus, and then the borehole can be placed inferomedial to this the junction. While some authority believe that asterion is not a reliable external mark for citing borehole. So some said that this on the left side of the slide is another reference point that one could use. So there is, from the root of zygoma, a line that is drawn in order to meet the inion posteriorly, and then another line that passes through the posterior profile of the mastoid process, as we can see here. So now the point of intersection of these 2 lines has been said to correspond to the junction of the transverse sinus and the sigmoid sinus. Then, so the first borehole can comfortably be made just inferomedial to this point. It's also good to note that the posterior end of the line, the iliozygomatic line, also corresponds to the distal part of the transverse sinus. Now, another structure that is also very important, that is worthy of mention, is superior petrosal vein, referred to as vein of Dandy. So this is a vein that drains the anterior part of the brainstem and the cerebellum, and it relates with its has relationship with cranial nerve. It has close relationship with cranial nerve 5. So when approaching a structure in a retrosigmoid, especially the upper neurovascular structure, one is may injure this superior petrosal vein, and if that happens, some complications may follow, especially when one is retracting the cerebellum. This vein may snap off and then begin to bleed. So the complication that may arise from this may be edema, because it drains the brainstem and the cerebellum. There may be edema of the cerebellum, and then there may be brainstem infarction. While some authorities have said that there may not be any complication even if this petrosal vein is injured or even transected intentionally. So now another landmark that has to be mentioned here is the suprameatal tubercle. So, and this tubercle is located at the posterior superior part of the internal acoustic meatus, as you can see here. So this structure is very, very important, especially when one wants to extend the retrosigmoid approach to other when you want to extend the retrosigmoid approach into the middle cranial fossa, as we know that the petrosal ridge here is the one demarcating the middle cranial fossa from the posterior fossa. So if there is an extension of a lesion into the middle cranial fossa, so this one can the suprameatal ridge here can be drilled in order to be able to assess either the Merkel's cave pathology or even sometimes petroclival pathology. So this image is showing the normal anatomy of cerebellopontine angle. As we can see here, so this space here on the is the cerebellopontine system, and we can see the internal acoustic meatus here on the bone window of this brain CT scan, the axial scan. And then on the MRI, one can also see this the cerebellopontine system here. Then these two isodense structures are the cranial nerve 7 and cranial nerve 8 on their way to internal acoustic meatus. So it's best appreciated on T2, while T1 one could not really appreciate it very well. Then this is the image is highlighting the internal acoustic meatus, as it can be seen clearly here. Now, there are common pathologies that may indicate the need to perform retrosigmoid surgery. Include the CP angle tumors. So the tumors in this region, the commonest of them, as I initially said, is vestibular schwannoma. It occurs in about 80
you have 2 more minutes
of cases. So, and then following this is meningioma, and then also there can some other lesions that may indicate retrosigmoid surgery is CP angle epidermoid cyst. And then there are also some vascular lesions that may warrant this approach. We have the aneurysm of vertebrobasilar system, is, mostly from posterior inferior cerebellar artery, or when there is vascular compression of cranial nerve 7 causing hemifacial spasm. So one may employ this approach. Or when there is compression of the cranial nerve 5 causing trigeminal neuralgia, so one can carry out microvascular decompression. Thank you. So from here, my co-presenter will take over presenting the operative principles. Thank you. Hello.
Can hear you, please. Go ahead.
Yes, my co-presenter.
Good evening, sir. I don't know if my slide is missing.
Yes, we can see it, please.
Thank you. Good morning, senior faculty, senior colleagues, my colleagues. I will continue. My name is Abdul Karim Saeed Umar. I will continue from where my co-presenter stopped. I will take the operative principle of retrosigmoid approach. I will use the following outline for the presentation from introduction down to literature review, and then I will conclude. As a brief introduction, the retrosigmoid approach is the most common route to the CP angle. This is because of the advantages that this approach has over the other different approaches to the CP angle. It provides an adequate visualization and a better panoramic view of the CP angle, as well as the lesions. And then it is one of the hearing sparing approaches to the CP angle compared to the lateral approaches, which are non-hearing sparing approaches. However, the disadvantage of this approach is the need for cerebellar retraction. The preoperative evaluation of this patient depends on the pathology that is located in the CP angle, and the patient will present based on the lesion that is available. The commonest lesion in the CP angle, as earlier alluded, is the vestibular schwannoma. For patients that are having this type of lesion, there is a triad of symptoms which involve progressive hearing loss, tinnitus, and unsteadiness. If the facial nerve is going to be involved, usually the facial nerve palsy is a late presentation in this patient because of the anatomy. The facial nerve is located anterior superiorly, and it is usually resistant to stretching. And trigeminal nerve may also be involved if the tumor is huge enough to go to the superior compartment of the CP angle. For patients that are presenting with CP angle meningiomas, the lesions may mimic that of vestibular schwannoma. However, the striking differences are as follows. The facial nerve palsy is usually early as against vestibular schwannoma. This is because of the relationship of the origin of the meningioma, which is usually at the superior anterior edge, and then the first nerve to be involved is the facial nerve. And then also hearing loss is usually late because of the anatomy. The vestibulocochlear is inferior posterior. And then the patient may also have the trigeminal neuralgia-like pain, which is more common than when it is vestibular schwannoma. Other lesions, vascular lesions, may also present, such as hemifacial spasm when there is compression of the facial nerve by aneurysm or tortuous blood vessels. Part of the preoperative evaluation is to also assess the function of both the vestibulocochlear and the facial nerve. This table shows the clinical assessment of facial nerve palsy using the House-Breckman facial nerve grading system from grade 1 to 6. It is important to document preoperatively, as facial nerve palsy is a common complication in CP angle tumors, even in those that don't have the facial nerve palsy preoperatively. And photon audiogram is an indispensable tool also to assess and have a baseline of the hearing function in the patient, as well as assess for the level of deficit, and then also help in determining whether the patient will go for a hearing sparing procedure or not. Usually, this grading by Gardner and Robertson help in identifying whether the hearing is a serviceable one or a non-serviceable one. Usually, patients with pure tone audiogram of 0 to 50 decibel have a serviceable hearing, while those that are having above 50 have non-serviceable hearing. Other evaluation tools include neuroimaging. This helps in coning down the diagnosis as well as ruling out other differential diagnosis. Brain MRI with internal acoustic canal protocol is the gold standard for the diagnosis of CP angle tumors, which we are going to discuss briefly. And then also the CT scan, it helps in identifying the anatomy of the internal acoustic meatus, the diameter, whether it is enlarged or not, and then also the pneumatization of the mastoid air cells. Angiography is also handy, especially in vascular lesions where the vessels in the CP angle are delineated by angiography. However, it is also useful to rule out the dominance of the transverse sinus. Usually in most individuals, the right transverse sinus is usually dominant, and this domination implies that it is the main sinus that is draining the blood vessels from the confluence, from the tubular. So as such, the transverse sinus on the right side will now be a little bit inferior from the superior nuchal line as it used to be. And hence, this will help in taking adequate precautions during sighting borehole. The internal acoustic canal protocol involves the following sequences that are performed in order to identify the lesion that is present in the CP angle and then rule out other differential diagnosis. This includes a thin section axial pre-contrast T1 weighted image, an axial and coronal thin section post-contrast T1 weighted image, T2, and then T2 flare, as well as DWI. Cysternography also is important to also identify the CP angle cistern. All these are aimed at ruling in or out the differential diagnosis of the lesions. The imaging features that one is supposed to look out for involves the cisternal extension of the tumor within the cerebellomedullary cistern, the degree of the brainstem compression, the intrameatal component of the tumor, and then the degree of master dogmatization, prominence of the jugular bulb, and the transverse sinus dominance, which is important for the jugular bulb prominence. If the jugular bulb is high riding, during drilling of the suprameatal crest, one may injure the bulb of the internal jugular vein, and this can lead to catastrophic bleeding intraoperatively. They also endolymphatic sac, and then anatomical rapport with the internal acoustic canal is also important. These are the things that one will look out for in the imaging. For vestibular schwannoma, the imaging features is that it is usually a non-uniform enhancement following contrast administration, and then it gives this typical ice cream on cone appearance for the lesions that are usually medium size. And so the cone is the internal acoustic meatus, while the tumor, it is the ice cream on it. And this lesion usually calcified. And then for those lesions that are very small, the internal acoustic canal is frequently enlarged by the tumor. The angle between the tumor and the petrous bone is usually an acute one when it is internal acoustic meatus, as opposed to meningioma, which usually gives an obtuse angle to the petrous bone. This is because of the origin of the tumor from the dural margin. That is the Kuss grading of vestibular schwannoma lesions in the CP angle. This helps in determining the grade of the involvement of the surrounding structures. It is graded 1 to 4. The 1 is intracanalucular, 2 when there is minimal tumor extension into the CP angle, and the tumor is usually less than 2, down to grade 4 where the tumor is greater than 3 centimeters. Another grading system is the SAMI grading, which is usually similar. And I will still also use this diagram to show the some of the features that are earlier described. As we can see in the A, we can see the tumor that is within the internal acoustic meatus. This is T1 contrasted image showing the hyper intensity of the lesion within the internal acoustic meatus. In this image, we can see the tumor is both within the internal acoustic canal and then also the CP angle cistern, down to a giant tumor that is greater than 4 centimeters, which has compressed the brainstem as well as the fourth ventricle. For meningioma, usually it has a uniform contrast enhancement, and the tumor may enter the internal acoustic canal, but usually it does not enlarge it. And the tumor appearance of the internal acoustic canal is usually an eccentric one. It usually calcify, and then also there may be hyperostosis of the internal acoustic canal, leading to narrowing of this canal, as opposed to widening when it is vestibular schwannoma. This image, it is a contrast-enhanced T1 weighted axial MRI showing pre-meatal and a post-meatal CP angle meningioma. On the A, you can see the dural tail and then also the obtuse angle that is being formed by this lesion, suggestive of a meningioma in the CP angle. And then this is the retromeatal, and then this is the premeatal. So other investigations that are necessary are baseline investigation in preparation for surgery, full blood count, differential UIE, random blood sugar, closing profile, chest X-ray, ECG, echo where indicated, triple serology, grouping and cross-matching, and then informed consent. And in the informed consent, it is necessary to discuss with the patient the possible complications that may occur, especially neural and a cranial nerve 7 palsy, which may occur even in patients that have intact facial nerve function. What are the intraoperative equipment and the devices that are necessary for this? The operating microscope is very important because it is a microvascular surgery, and neurophysiological monitoring for the facial nerve motor evoked potential, as well as the brainstem auditory evoked potential for the cranial nerve 7 and 8 respectively. This is necessary intraoperatively to prevent injury to these nerves, and when it is detected early, it can actually be repaired. Craniotomy and the use of diamond drills is important. Use of lumbar drain depends on surgeon's preference. Large tumors, some surgeons may want to put a lumbar drain preoperatively in order to help in draining of CSF. However, some surgeons do not use this. They prefer to do the early cystanotomy to let out CSF. Use of CUSA is also important for the tumor work in order to help in intratumoral debulking of the tumor. We'll see subsequently the benefit of use of CUSA. Neuronavigation is handy in delineating the transverse and the sigmoid sinus in some instances, and then also it helps in the precise localization of the tumor intraoperatively. However, it's used in retrosigmoid as well as other CP angle lesions is not very frequent. So what are the anesthesia and the positioning consideration in these patients? Usually, general anesthesia with endotracheal intubation using armored tube, capnograph, and then use of arterial catheter. The capnograph is important in early detection of patients that have air embolism, and then arterial catheter helps in real-time monitoring of blood pressure. Muscle relaxation is usually delayed until after stimulation of the facial nerve, because if the patient is relaxed at the onset of the surgery, when one needs to stimulate the facial nerve, there may not be any effects that will be observed. So it is after stimulation of the facial nerve, then the patient will be relaxed using the muscle relaxant, and then the procedure will go ahead. The use of transesophageal echogram is a preventive measure in order to identify early if there is air embolism. And then the central venous catheter with the tip at the right atrium helps to aspirate air that that has embolized intraoperatively. So the positioning of the patient is as important as the surgery itself, and there are various positioning that can be employed for retrosigmoid approach. These include the semi-sitting, the supine, prone position, and then the park bench. But for the purpose of this presentation, we are going to describe briefly the park bench positioning. This diagram showed the position of a park bench for retrosigmoid approach in a patient, and we can see that it is important to mention that the park bench positioning is a modified lateral position. The patient is put in lateral position with the reverse Trendelenburg, and then the head is fixed on the 3-point Mayfield holder, and then it is gently rotated towards the floor and slightly flexed towards the chest, and allowing a room for about minimum of 2 finger breadth. and then the head is laterally flexed, with mastoid tip being the most superior point that is horizontal and parallel to the floor. Pressure areas are usually padded. The superior upper limb, as we can see, is placed on an armrest, as well as the inferior or the non-dominant upper limb is also placed on an armrest. The shoulder and as well as the hip, they are strapped using adhesive band, and then also the pressure areas are padded. Following adequate positioning, the anatomical landmarks that are used in order to identify the incision site are as follows. The root of the zygoma, which will now give us the iliozygoma line, which has been described earlier on. As we can see, this is the iliozygoma line, and then the tip of the mastoid process, a line perpendicular to it. Where these two lines meet, that's the point where we have the transverse sigmoid junction. And this is targeting that junction. The point is targeting the junction, and then an incision will now be made at the passing through that that junction. So there are different incisions that can be made: the C shape, the linear, the lazy S, and then hockey stick incision. Whichever incision is made, the aim is to expose the posterior margin of the mastoid process and then the suboccipital area. However, care is supposed to be taken in order to prevent injury to the lesser occipital nerve. However, if the injury to the lesser occipital nerve is incurred during surgery, the two ends of the nerve is usually tagged and then left with a suture. After the surgery, it is usually anastomosed and then repaired. So this is an intraoperative image of a patient that had retrosigmoid approach in our center, where the marking of the incision site is being made. And then, as we can see, this is after the dissection, and then the soft tissue has been elevated off the field. So the incision, there is a guiding rule for the incision for the curvilinear incision. That's the 564 incision, 555, and then the 546 incision. This is determined by where the surgeon wants to operate. For the patients that for the exposure of the transverse sinus, 5 millimeter of incision medial to the mastoid notch, which is also placed 6 centimeter above the notch and then 4 centimeter below it, it will expose the transverse sinus. If one wants to approach the middle part of the CP angle to work on the 7th or cranial nerve complex, the 555 incision is made. This is 5 millimeter medial, and then 5 centimeter above and 5 centimeter below the mastoid notch. And then similar incision is also done for approach to the lower cranial nerves. The area is shaved, clean, and infiltration with lidocaine and adrenaline 1 in 200,000, and then routine cleaning and draping will be done. The skin incision is usually taken down to the pericranium and reflected towards the auricle. And the muzzle and the facial plane, it's usually dissected off the field. The muscles of the suboccipital triangle, as earlier alluded, they are reflected inferiorly. And this will expose the operative field, where we can appreciate the digastric notch, and then the tip of the mastoid process, and then also the mastoid emissary vein, which is an important landmark to identify where the transverse sigmoid junction is. This mastoid emissary vein is draining into the junction of the sigmoid and the transverse sinus. So we can see on this image the outline of the transverse, the transverse and then the sigmoid sinuses, venous sinuses. The borehole is usually sited just inferior to this junction. That's the first borehole. And the borehole, it's connected, and then using craniotomy, it's a window of about 3 centimeter widest diameter is usually efficient for most procedures to expose the CP angle. This craniotomy, it's usually bounded anteriorly by the sigmoid sinus and superiorly by the transverse sinus. This is an image that showed the stepwise craniotomy for the retrosigmoid approach. As we can see, the size of the craniotomy flap is less than 3 centimeters, which is sufficient for this procedure. And it is important to note that immediately after removal of the bone flap, the mastoid air cells that are exposed are supposed to be plugged with either bone wax or a fat graft. This is to prevent air embolism, and then also subsequently CSF leak can also be encountered. This diagram showed the exposure of the dura and then commencement of the dura work. Hemostasis is usually secured over the dura, and then a C-shaped incision is done starting from the inferior aspect of the craniotomy. This is done gently in order to allow a gradual CSF letting out in order to reduce the pressure that is in the CP angle and then allow the cerebellum to retract simultaneously. So the dura is usually placed anteriorly, and this corridor that is created, it's now enough to enter into the CP angle. And retraction of the cerebellum is generally avoided. However, if it is necessary, it is usually applied gently, and then dynamic retraction is what is advocated, using just suction nozzle to be retracting the cerebellum. At this stage, microscope is deployed, and dissection is continued. So this diagram just showed a guide as to where to apply a retraction depending on the structures that one want to expose, whether it is the superior, middle, or inferior part of the CP angle. So after the retraction of the cerebellum, the next structures that will be appreciated are the structures in the CP angle. And as we can see from this diagram, you can see the upper and the middle part. This is showing the X cranial nerve, and then the fifth cranial nerve is not depicted in this image, but we can appreciate the ninth and then the 10th, and then we can see the piper. This showed the tumor that originates from vestibulocochlear nerve, and over it is the anterior cerebellar artery. And here is depicting the intracanalicula part of the tumor after dural incision over the petrous bone. So at this stage, the tumor work can begin, and this is where CUSA, if it is available, can be employed in order to commence the internal tumor debulking. So this is a microscopic view of the arachnoid stage of the dissection, where we can see the micro scissors and the dissection of the arachnoid exposing the tumor. And then it is important to note that superiorly, the extent of the dissection may be limited by the superior petrosal vein, which is an important landmark in the CP angle. This is where the superior petrosal vein is located, and it is identified usually as an inverted Y structure. And care is supposed to be taken in order to prevent injury to the superior petrosal vein, because or negating it, because there may be venous congestion and infarction of the cerebellum as well as part of the brainstem, which this vein drain. So this is another microscopic image showing the tumor and then also the structures as earlier alluded.
Please,
So
you
the
have 3 more minutes. Please, you have 3 more minutes. Thank you.
Thank you, sir. The principle of this tumor excision involves early identification of important neural structures commencement of internal tumor debulking, and then also use of bipolar coagulation is extremely avoided in order to prevent injury to the surrounding neurovascular structures. Where use of bipolar insulated bipolar forceps can be used, and then the minimizing hemorrhage and avoiding. After the compression, the tumor capsule is usually attached deep into the internal acoustic canal. So this is where the drilling of the suprameatal crest is necessary. As you can see, this is where the drilling is done, and then the final attachment of the tumor is chased, and then it is detached because of the area where it is originating from. At this stage, injury to the labyrinthine artery is supposed to be avoided, as the patient may have hearing deficits post-operatively. The labyrinthine artery is a branch of the internal, of the ICA, and it supplies the hearing apparatus. The drilling should not be beyond 10 millimeter, as this may risk injury to the vestibular apparatus, and then this can lead to hearing loss. Post-operatively, the reconstruction include a watertight dural closure to prevent CSF leak, return of the bone flap if craniotomy is done, and if craniectomy is done, the bone flap is either kept or discarded. Soft tissue closure is done, and it is important to note that there is a suprameatal extension of retrosigmoid approach for middle cranial fossa, or tumors that are predominantly in the CP angle but extending into the medial part of the middle cranial fossa. This extension involves the drilling of the suprameatal in order to reach the middle cranial fossa, especially at the region of the Merkel scale. Endoscope-assisted microsurgical technique also help in increasing the panoramic view that is not obtainable using microscope. Post-operatively, patient needs intensive care unit, and then also post-op IV fluid and analgesics, as well as antibiotic where necessary. The ICP monitoring is also important in this patient because of the region that is being operated. Complications involve general complication as well as procedure-related complication. General complication due to anesthesia, positioning, air embolism and pressure, surgical site infection, and then wound dehiscence. CSF leak is one of the commonest complications of the retrosigmoid approach, and this is due to injury to mastoid air cells, and then also leakage can be from the durotomy site, and then also from the suprameatal drill, where CSF enters into the middle air, and then it leaks from there. Facial nerve palsy also, which is commoner in tumors that are greater than 3 centimeter. Worsening of the hearing impairment can occur following nerve retraction or overheating and vibration to the nerve. The follow-up involve MRI with IAC protocol in order to determine the residual tumor or recurrence. Complications can also be determined using the imaging. This includes fat graft necrosis, CSF leak, among others. This is just a brief literature review that look at papers that have compared the different techniques in the reconstruction. On my left, and then on my side, it's the use of 3D computer tomography venogram in order to increase to prevent persistent headache attributable to craniotomy. This is also a paper showing the possibility of microsurgical resection of a large petroclival meningioma through an extended retrosigmoid approach. And then the last one is a local paper where 28 patients that had skull-based surgery were reviewed. One of them had retrosigmoid approach. In conclusion, the suboccipital retrosigmoid approach remains the most commonly used surgical route for the treatment of CP angle lesions. A close assessment of the surgical indications, careful planning of the procedure, meticulous surgical technique, as well as the use of neuro electrophysiological monitoring are essential to achieve the best surgical outcome. Thank you. These are some of our references.
Yeah, thank you to our presenters, Dr. Muhyiddin and Abdul Karim. Before we proceed to the question and answer session, it's a privilege to recognize the presence of Professor Jimo and my trainer, Professor Olufemi Bankole. You're welcome, sirs.
Is he hiding in the census?
Yeah, the floor is now open for questions and contribution. One can drop his question in the chat box, and I'll read it out to the presenters. Please indicate by a virtual show of hands. If there is no questions, I would want to bring on our faculty.
Sorry, Dr. Jude, I think somebody else is not Dr. Campbell.
Yeah, hello. Can you hear me?
Please.
Hello, can you hear me?
Yes, please, Dr. Campbell, go ahead.
Yes. Just a few comments. I don't really have a question to ask. I was really impressed with the presentation, especially the second presenter. I went to real details about the surgical approach, and the essence of the surgery and so on. I just want to highlight a few things, and I have a lot of residents in the meeting. He talked about the asterion being the point of inserting the borehole, and he may give other examples. Generally, asterion is not such a reliable site of siting the borehole. And usually, even if you must use the asterion, it has to be below and anterior to the asterion. Siting it on the asterion may injure the sigmoid sinus. And then there's an anatomical localizing the structures in the IAC. We usually use a code when we are residents. The Bill's bar and the transverse crest divides the IAC into 4 sections. And we use the 7 up, coke down. That makes us a mnemonic that helps us remember that. So 7, which means the 7th cranial nerve is up anteriorly. Then the cochlear nerve is down anteriorly, while the superior and inferior vestibular nerves are both superior and inferior posteriorly. That's a simple mnemonic to remember that. And third point I want to make is based on the incision. A lot of arguments about what incision is best and which one gives the better outcome. I think they are all the same. Depends on surgeon's preference. But some Japanese described a multi-layered approach where they make a C-shaped incision and they dissect the occipital muscle in a layered manner. So by the end, or like other incisions, the linear incision and the J incision, where you divide the muscle, you transect the muscle. In this one, the muscle are detached from the attachment to the occipital bone and raised as a flap, just like when we are doing pteronial craniotomy. They argue that the advantage of that is that you don't divide the nerve supplying the muscle, the occipital artery is preserved, so they have lesser incidence of atrophy and lesser occipital headache. One of the problems of this approach is a lot of times patients have complain of recurrent occipital headaches. So those are arguments. But I think most times surgeons do what they are very comfortable or they are used to. And finally, I think the most important thing here, to prevent CSF leak, you must wax in and wax out. So as you are going in, you meet the mastoid air cell. You must wax in. Then when you are coming out, you must wax out. And some people described using a muscle, to occlude the mastoid air cells to prevent CSF leak. So those are small points I want to add. But I think overall it was an excellent presentation by the 2 presenters. Thank you.
Yeah, thank you, Dr. Campbell. Dr. Kambinga, please, can you unmute yourself? Go ahead.
Yes. Good afternoon. First of all, thank you so much for the presentation. I just joined when Dr. Abdel Karim was doing the surgical technique. That was really great, really in details. Thank you so much. I just have a quick question regarding the post-op. You talked about ICUK and analgesia, but you also talk about ICP monitoring. I just wanted to know how will you monitor the ICP in those cases? Do you mean that you will place ICP monitors, or what do you mean by that? Thank you so much.
Dr. Abdul Karim, please, can you respond to the question?
Thank you so much, sir, for the opportunity. Thank you for the question. Yes, the monitoring of ICP is not routine in all patients. However, for patients that present with a giant tumor causing hydrocephalus, ab initio there is hydrocephalus and then there is raised ICP. So post-operatively, those patients may be needed to be monitored using the invasive intraoperative invasive ICP monitoring. So for this kind of patients that may need even EVD, because some surgeons use EVD pre-op and then follow after the surgery, if there is need to maintain the EVD, they leave it and then they will now use that same EVD to monitor the ICP. But if there is no need for the EVD, it will be taken out and then the patient may not need the ICP monitoring. So it is not routine, it is individualized in the patient that need it.
Okay.
Thank you.
There are other questions in the chat box. One of them is, how would you identify the facial nerve and prevent injury, especially in a resource-poor environment without neuromonitoring? Dr. Abdul Karim.
Thank you, sir. The identification of the facial nerve is very important in CP angle tumor surgery. Yes, in resource limited environment where neurophysiologic monitoring is not available, one will rely on the anatomical disposition of these structures. The anatomical disposition of the facial nerve as well as the vestibulocochlear nerve is always constant in the internal acoustic meatus. So the facial nerve is usually superior anterior to the vestibulocochlear nerve, which is posterior inferior. So if one can trace the nerves to the internal acoustic meatus, the facial nerve can be identified. However, lesions usually distort this anatomy. So it is always said that one should be careful in order to prevent injury to this nerve. So by commencing with internal tumor debulking, if you have neuroelectronic electrophysiologic monitoring, the first thing you are going to do before you commence your internal tumor debulking is to stimulate. Once you stimulate, you identify and you avoid. But if you don't have it, you have to be as careful as possible to start with the tumor debulking. Once you do your tumor debulking, the whole space will now become clear, and then you will be able to identify the nerve using the anatomical landmarks. I hope this answers your question. Thank you so much.
Permit me to also mention that in our settings, tumors are usually very big and the facial nerve is thinned out, that without neuromonitoring, it's pretty difficult to identify it. The other question is, since radiotherapy is also an option, which group of patients will benefit from surgery only?
Sorry, sir, I didn't get the question.
Since radiotherapy is also an option, which group of patients will benefit from surgery only?
Okay, thank you, sir. Usually patients that are having benign lesion, like vestibular schwannoma is a benign lesion. So if one has already achieved complete tumor resection, this patient may not need any follow-up with radiotherapy.
Okay. The last question in the chat box here, it's how would you surgically manage a patient with bilateral vestibular schwannoma?
So for patients that are having bilateral vestibular schwannoma, it depends on the presentation. If the patient have complete bilateral hearing loss and there is no features of raised ICP, no compressive symptom on the brainstem, the patient can actually be followed up. However, if there are associated, there is hearing sparing, and then also all there is associated features of raised ICP, this patient, or brainstem compression rather, this patient needs surgery. And the serviceable air is usually the one that is supposed to have surgery first, and then subsequently the non-serviceable air. And this can be done in stage surgery or in the same sitting.
Thank you, Dr. Abdulkarim. That's all the questions for now. Before I bring on our faculty, it will be a privilege to get contributions from our teachers, Professor Jimo and Professor Bankole. I don't know if you have any comment to make, sirs.
Thank you so much for anchoring this session. I have no comment much. The presentation is coming from my center. So other than say, okay, they've done very well, and I'm just hoping the discussion goes smoothly. Thank you so much.
Professor Bankole, I don't know if you kindly have any comment to make. Okay. All right. Our faculty for today is Professor
Dr. Jumudu. Dr. Fred.
Yes, please.
Yeah, please. We have Professor Yomi Ogun here, a foremost neurologist. Probably he has one or two things to say before the faculty is brought on. Thank you very much.
Thank you.
Well, just to commend everyone for very brilliant deliveries. And some of the concerns has been addressed already. Well done. I mean, it's been very well coordinated, and the deliveries are very excellent deliveries. So please keep up the good work. Well done. Thank you. Yeah.
Thank you, sir.
Thank you, sir. Our faculty for today is
Sorry,
an erudite
Professor.
scholar.
Sorry, sir. Professor Aminata is in the house. I hope she is still there. I think she's an international faculty. So if she could say one or two things. Professor Aminata from Niger Republic. I think she has exited. All right, go ahead, please.
Thank you, Prof. Our faculty for today is Professor Ozo Ignatius Ikemefuna. He's a professor of neurosurgery and human anatomy and a chief consultant neurosurgeon. He had his first degree at the University of Benin, and also acquired master's and PhD in neuroanatomy, neurosciences, and surgical pathology. He had his residency training at UNTH with international exposures in India and Ghana. He is a fellow of the West African College of Surgeons and International College of Surgeons. He also has additional diploma in management and medical education. He is the current acting provost, College of Medicine, State University of Medical and Applied Sciences, Igbo Eno. He is the past head of Department and Neurosurgery Unit, Est College of Medicine. He is a past Associate Dean and Dean, Faculty of Basic Medical Sciences. He is an erudite scholar that has published 60 plus articles in both local and international journals. He has supervised quite a number of undergraduates, masters, and PhD candidates. He's currently a chief consultant neurosurgeon at ESUT Teaching Hospital, and he has performed 1,800 plus of neurosurgical cases. He's an eminent UN ambassador of peace. He is also a director, May and Great Venture Nigeria Limited. He's also the CEO of Teresa Honorego Brain Healthcare and Education Foundation. He's a practicing Roman Catholic, married with children. Prof, you're welcome, sir.
Yeah. Thank you very much. Good evening, everyone. I'm actually privileged to be in your midst this evening. Can you hear me? Hello?
Yes, Prof. Professor also can hear you, sir.
All right. Thank you. Thank you, Dr. Guga. Thank you, the presenters. Due respect, Professor Jimo, and our president, Professor Bankole. I'm happy to be in your midst this evening. I want to say that the lecture, the topic is well chosen, and the presenters have done smartly. They've done very well. Excellent presentation, excellent arrangements, and their delivery were superb. So coming to the topic of today, I think they have done very well. And a few things are what I want to, mention in terms of contribution or re-echo what they have said in some at some stage of their presentations. I want to say that first is in the assessment of patients that are presenting with CP angle tumors. I think you should always, especially for the residents, to have at the back of your mind that there should be adequate evaluation of these patients. And all the evaluations should be Hello, can you hear me?
Yes, Prof.
So adequate evaluation of these patients are very, very important, especially to the fact that most of them may be presenting with hearing impairments. And when that is done, it should be well documented because of possible associated complications, such as worsening of hearing. In the course of assessment, we should note the status, the hearing function, and the hearing status of these patients, and possibly document it very clearly before intervening surgically in such patients. They should also be seen as possibly, personally, I see them as maybe semi-high risk patients when it comes to hearing function after surgery. And the consent should be well taken and well documented. In terms of neuroimaging, you have mentioned the very CT. All of them complement one another. You cannot just do CT scan and proceed your surgical treatment. You must complement it with MRI, and the operating microscope is also very, very important. It is a must in this era. I mean, initially when we were doing our training, we didn't have operating microscope. Some patients coming with this kind of ailments, we may not be able to handle them properly, even though we have loops. But currently, I think I advocate that any person that wants to manage this patient surgically should be sure is using a very good operating microscope. Another thing that is key is understanding the anatomy of this area. The anatomy is not, you cannot say that you have known it all. It's something you should, go over and over, even as a resident, even as a consultant practicing. Whenever I want to do this, you go through the anatomy again. And for the residents, as you're going through the anatomy, draw the structures, the contents. That's where you drive it into your brain. so that as you are operating in the, no matter the corridor you are taking to assess the lesion, you know the anatomy from beginning. Where I was, like when he presented the citation, when I were in there with Atogue, there is no surgery you will do, especially skull base or CP angle tumors. The residents must draw and draw up to 3-4 diagrams to be sure you really understood the terrain where you are going to. And they paste it on the wall so that as we come, that's the first thing you take everybody through to see the diagrams, see the arrangement of these nerves that the presenters mentioned. And when you are conversant with that, at least you are sure that the complications will be drastically reduced. So to that effect, I think I'm prescribing that centers should actually have cadaveric dissection, dissection and cadaveric approach to the CP angle. You can make borehole on cadavers, practice it, know when we're talking about asterion, when we're talking about mastoid, you know it. See all the places where you have you are expecting air to come from, and the misery veins, the bleeding aspects, even though it will not be very clear in cadaver, but at least it will help us to be used to that area before now going into live patient to operate. So when we master the anatomy very well, it becomes clearer, and we'll be sure of the corridor we are going into. Another thing that I want to also point out is the presenter we are talking about craniotomy. And I want to say in a few times I've been involved in CP angle Retrosigmoid approach to CP angle lesions. We preferred to use cranectomy. And when you sight your borehole, usually about 5 cm or more, you'll be able to assess no matter where the lesion is. And if it's not enough, you can gently nibble or drill to expose the transverse sinus and the small sinus. We never had to return the bone in terms of returning the flap. So we use that singular borehole to expand if there is need, or we work with the borehole. So because the muscles, the suboccipital muscles there are enough to give good padding to the area. And it's also noticed that when you return the preferred, even though he said you may return or discard. Cranectomy in all the ones that have been involved has been what we use to interpret. Hello, can you hear me? Hello?
Yes, sir.
Okay. So
Yes.
cranectomy versus craniotomy, yeah. Then when he was also presenting at the point, I don't know whether it was their routine in Zaria, but at the point where he said that you bring in microscope, personally, the ones who have been involved will bring microscope earlier, even before durotomy. It will also help you to visualize, sinuses proper, venous sinuses before, at a time when he talked about bringing in that, at this moment you bring in your microscope, was almost when he was talking about whether you are retracting or lifting the cerebellum, the hemisphere of the cerebellum. So I think you have to bring the microscope early. As you are going in, you're advancing your microscope so that you see, as you are going into the bed, you already see structures to be avoided and the lesion to be operated on. Then, before now, it has been a struggle actually to operate at CP angle tumors. Not that the surgeons around this place cannot operate, but because of limited equipment, to use to operate in such a tight area. But with CT scan, MRI, angiography, we can now do better. But we have to still do more to know whether any center can, acquire to improve to the extent of using intraoperative monitoring, because it's very, very essential when operating at CP angle tumors. When I finished, a year training in India when we were doing residency, we came back here and most of these things are not here. And when they are not there, it limits someone's performance. So if our different centers make effort to know, or if there is any center that already have this monitoring, then we can pull some of these patients to that place. And with that, we'll be able to boast that we can get minimal complications from these patients. And the intraoperative monitoring will include, he mentioned some of them, central venous pressure line, put arterial lines, can do ECG monitoring, Doppler, ultrasonic flow, brainstem function monitoring, then cortical spinal tract monitoring by somatosensory evoked potentials. All these things are what are now being used. You can also monitor cochlear function by using brainstem auditory evoked potential, then intraoperative electromyography for facial nerve. So ECG also can be placed, to monitor arrhythmias, bradycardia, which will point to early injury to the brainstem. So we may not get all these at once, but at least the ones that we can do around here, we should be encouraged to use them. And we can also use physiologists. Nowadays, we have people with physiologists that we can just send for training to acquire, this knowledge and skills, and come and assist us in the theater to monitor this. And that will help us to come out with a good outcome. So I think I will stop here, and probably if the discussion goes on, maybe I can come in again if there is need for that. Thank you very much.
Thank you to our faculty, Professor Ozo, for your concise talk on Retrosigmoid approach. I would, at this junction, hand over to Dr. Adeboye to continue the discussion. Thank you.
Yeah, thank you very much, Dr. Fred. It's been a wonderful discourse this evening. We want to thank the Vicente Center, Ahmadu Bello University Teaching Hospital, under the tutelage of Professor Jima Abdullahi. I will thank our faculty for the day, Professor Ozo, and all the erudite professors who are here, Professor Edwin, Professor Ogun, and distinguished leaders and elders, both within the country and outside the country, and all the participants, both local and international. We are very grateful. Under the leadership of YNNF, Young Nigerian Neurosurgeons Forum, Dr. Guga, we are all grateful for your participation, and the nuances and the pairs that we have gained this evening will stay with us, and we are going to build on it. I thank everyone for placing this occasion this evening. It's a monthly webinar, and so 29th of August will be another section. We'll be dealing with upper cervical spine pathology. Thank you very much. The recordings of this webinar will be made available on YouTube and be posted in due course. Thank you very much. Have a wonderful weekend. Thank you, everybody.
Thank you so much for the coordination.
Thank you, Prof. You are great, sir. Thanks so much, sir.
You're welcome. Thank you. Thank you.